So
First,
Dr. Pelosi, do you want to do this one?
Yeah, sure. So I have to catch your breath. Which of the following statements is not true? A lumbar puncture is essential in diagnosing TB meningitis. B, a large volume, that is 10 to 15 mils, will increase the diagnostic yield for TBM. C, a negative smear, culture, and expert rules out TB meningitis. D, start empirical treatment when you suspect TB meningitis. Let's have good voter turnout. We are 94 of us. What do you think the answer is? Which of the following is false? A lumbar puncture is essential in making a diagnosis of TB meningitis. E, a large volume will increase the diagnostic yield. That's 10 to 15 mils. C, a negative smear, a negative culture, a negative expert rules out TB meningitis. D, start empirical treatment when you suspect TB meningitis. We have less than 50% voter turnout. This is a very complicated way of voting, Kote. So we will share we'll end the poll and share the results. I don't know if people can see the results. To be honest, I really don't know how it's done, but I hope people can see. So most people actually feel that a lumbar puncture is essential for you to make a diagnosis of TB meningitis. Dr. Herce, just take notes so that when you explain the answer, people note that. Of course, a few people also feel that starting empirical therapy when you suspect it is a good idea. We'll stop sharing and you can continue with the presentation.
So should I give the answer now, Dr. Pelosi?
We'll have a look at it at the end.
Okay, great. So after we do a good history, we do a physical exam, and I'm just going to share some diagnostic pearls. So this is really an example of TB lymphadenitis. And as you can see in this picture on the left, and also here on the right, often you'll see a combination of lymph nodes, usually in the posterior cervical chain, which you're seeing on the left behind the sternocleidomastoid muscle, or occasionally in the supraclavicular area on the left. And often it will spontaneously drain, as you can see in this picture to the left, there's a little bit of fluid. But this is an opportunity to make a diagnosis. And in our setting, we'd worry first about TB lymphadenitis, but we'd also think about lymphoma, especially if the patient has HIV. So we can make a diagnosis using a fine needle aspirate, and we can put the aspirate fluid onto a slide for fluorescent microscopy, or ideally we can put it into a sterile test tube and have it run on GeneXpert. Lastly, if you have surgical colleagues and the lymph node is large, you could excise it, particularly if you're worried about lymphoma or there's other conditions on your differential for histopathology. An AFB stain on the lymph node tissue itself can also yield a diagnosis. On the histopathology, you'd also see caseating granulomata, which is pathognomonic for TB lymphadenitis. So these are often really good sites for sampling, and we can get a microbiologic diagnosis in most cases. And there's been sort of big reviews from WHO showing that Expert really has a role in these sorts of cases where there's purulent fluid or a lymph node. It can help us make a diagnosis. The next part of the exam I think about is the cranial nerve exam. And Although this is not pathognomonic for TB meningitis, often when patients present in the sort of second and third phases of TB meningitis, in the meningeal phase or stuporous phase, they have extensive cranial lymph node or cranial nerve involvement. And the reason for this is actually cranial nerve 6 has the longest pathway from the midbrain to the end site. So here it's the lateral rectus muscles of the extraocular muscles of the eye. So what you will see is on the affected side, the individual is not able to abduct the eye and look laterally. So in this patient that you're seeing here, there's involvement of the left 6 cranial nerve, and the individual is asked to look left. The right eye can look left, but the left eye cannot. And we typically see this when there's increased intracranial pressure or increased intracranial inflammation or inflammation of the meninges. And you can see that in TB meningitis as well as cryptococcal meningitis. For skeletal TB, often, frankly, the most common presentation that we see on the wards is lower extremity weakness or impairment of reflexes that comes from Pott's disease. But early on, you can see a sort of angulated kyphosis, this abnormal curvature of the spine, which you're seeing in this right picture with the arrow. And you can often see a draining wound, which in this patient in the left panel on the lower side, there's involvement of the lumbar spine and there's been some drainage. Unfortunately, these patients often present late, but if you see any of these skeletal abnormalities, you should obtain an X-ray and should think strongly about Pott's disease and skeletal TB. Often we make these diagnoses empirically based on presentation or classic radiographic findings, which I'll go over. It's often very difficult to make a microbiologic diagnosis, so we will often initiate therapy in these cases empirically. Once we've done a physical exam, we often rely on radiology. So I just wanted to share sort of 2 classic X-rays that I think many of you have seen before. This left panel is a right-sided TB pleural effusion. And what you can see is just total blunting and ossification of the right costophrenic angle and the right border of the heart. Often these can layer, but if it's chronic, it may not because of loculations. And then on the left is a classic miliary TB, and you can almost imagine sort of scattered millet seeds throughout the lung fields that would be appreciated on X-ray. Here are sort of X-rays for skeletal TB. So on the left is from that same patient I showed you earlier who had Pott's disease. And you see severe angulation because the vertebral body has collapsed, which you can see in this arrow. And you get what's called a classic gibbous, which is basically this angular deformation that can be quite acute and causes a hump. On the left is a picture of the left hip joint, and you can see sort of the joint space is obliterated. And on the superior portion of the joint space, you see a lot of osteophytes, so deposition of new bone, which suggests remodeling, inflammation, and erosion. And this is classic for TB arthritis with destruction of the joint space. It is less frequent that we can get access to MRI or CT of the head, but I do want to point out, one kind of clinical entity, which is the tuberculoma, which you can see on the CT scan of the head that's done with contrast on this right-sided panel. So you see in the occipital lobe, this sort of well-characterized 3 to 4 centimeter lesion that is ring enhancing. You see that enhancement with the contrast and sort of central area of darkness. And then all of this dark area on the contrasted study suggests brain edema. So this is a classical presentation of a tuberculoma, and likely the patient would have some sort of central visual disturbance because of involvement of the visual processing centers of the brain. On the left here is an MRI of the brain, which we have less access to, but is really classic for TB meningitis. And you can see on panel A, there's sort of this white brightness around the midbrain, and this is all basilar enhancement. And TB meningitis has a predilection for the midbrain and the brainstem, and can cause multiple cranial nerve defects, as well as change in mental status. This is typically seen sort of at end stage TB meningitis, but this is sort of the radiographic finding you might see in someone with coma. And then you also see some mild dilatation of the lateral cerebral ventricles. And then in panel B, you see meningeal enhancement, which suggests this brightness and thickening of the meninges that are bright white, and sort of some of the surrounding vessels suggest TB meningitis. A last phenomenon that is common in both TB meningitis and in syphilis is sort of having a vasculitic presentation to be TB meningitis. So the patient can almost present like they have a stroke, but instead of stroke from high BP, diabetes, they have a stroke from sort of hypercoagulable and in situ inflammation in the arterioles of the brain that can cause focal neurologic deficits, and you would pick that up on an MRI. So now I have a mini case I'd like to review with you. So this is the case of a 35-year-old man, newly diagnosed with HIV, who's coming to your primary health center in Lusaka. He has a CD4 count of 189, and he tells you that he's had 3 weeks of fever, palpitations, chest pain, shortness of breath, and 8-kilo weight loss. You examine him and notice that he's febrile with a temperature to 38.6. He's tachycardic, pulse of 126. He's got bilateral posterior cervical lymphadenopathy. And on your chest and heart exam, you notice that his heart sounds are distant, his neck veins are distended. He's got right upper quadrant, tender hepatomegaly, and he's got pitting edema involving the feet. Unfortunately, the patient cannot produce a sputum sample to provide for expert, but he is able to undergo a chest X-ray. And you notice the following X-ray, which shows a globular heart and a large cardiac silhouette and straightening of the left heart border. So this is poll question number 2, and I'll hand it back to Dr. Filoshi.
Based on that scenario, what would be your most appropriate next step? Is it A, to prescribe a 10-day course of amoxicillin? B, refer to UTH for an echo to be done in 2 weeks and follow up with you in 3 weeks? C, advise patient to return for a repeat X-ray in 2 weeks? D, start ATT and the steroid taper for 11 weeks for presumed TB pericarditis and refer to UTH. We'll allow the second poll. What do you think we should do with this gentleman with a CD4 of 187 presented with fever, chest pains, and the chest X-ray that showed straightening out of the right cardiac border and a very globular heart? What would you do for this patient? He's been unknown for a few weeks. Would you prescribe 10 days of amoxicillin? Would you refer to UTH for echo to be done in 2 weeks? Would you tell the patient to go home and come back after 2 weeks so that you check for progression of the cardiomegaly? Or would you start ATT and the prednisolone taper and refer? Okay, this polling seems to be going well. We have 120 connections and only 60 people have voted. Please go ahead and submit your answer. You have a male with a CD4 of 187 odd, HIV positive, presents with chest pain, fever, hepatomegaly. When you do an X-ray, you can see a globular heart and a straightening out of the right heart border. What would you do for this patient? Would you give some antibiotics for 10 days? Would you refer for so that it's done electively after 2 weeks? Would you advise the patient to repeat a chest X-ray after 2 weeks? Or would you actually start ATT and then let them and refer them? Remember, he also has lymphadenopathy, hepatomegaly, fever. We'll end the poll. So that is the thought of the network. Most would start ATT empirically with a steroid for TB pericarditis. Some would refer the patient for echo. Others would advise the patient to return for an X-ray after 2 weeks. A few people would actually prescribe antibiotics for 10 days. We can go ahead with the presentation.
Great. And just to jump in for this last one, I think the crowd is very smart. So yes, this is TB pericarditis. And I think the teaching point here is that, this patient is presenting with sort of advanced TB pericarditis. They have a large effusion. So there's total obliteration of the left heart border, and the heart is globular. So more than 50% larger than the typical cardiac silhouette on X-ray. The patient has evidence of severe edema and shortness of breath. And in our setting, this is going to be the most common cause of infectious pericarditis. And time is of the essence. So in this patient, the most appropriate next step would be to start TB treatment and to initiate that with prednisone, because the pericardial sac is a fixed space, and the kind of extent of advanced TB pericarditis in this case means that the patient is at risk for developing a constrictive cardiomyopathy, meaning that the pericardial sac will become scarred and that the patient could present to pericardial tamponade. So steroids prevent that from happening in these cases where the individual may be at increased risk of developing constrictive cardiomyopathy physiology. I wanted to spend a little bit of time just talking about TB meningitis as well, because that is a very common entity and it comes with high morbidity and mortality. And just to say that a lumbar puncture is really essential for making the diagnosis. It really helps us. So if we do an LP, we often see that the cell count is elevated. Remember, normal should be 0 to 5 in people living with HIV. So that if you see that it's elevated and you see a predominance of lymphocytes or monocytes, that's highly suggestive of TB meningitis, particularly if you see elevated protein and a low to low normal glucose. To make to acquire enough CSF to do all the necessary diagnostic studies, we usually want to get what's called a large volume lumbar puncture. So we take out 10 to 15 mLs of CSF so we can send it for GeneXpert and also smear. Smear really doesn't help us much. Expert can, and sensitivity can be as high as 80% off of one sample, as well as culture if we have access to it. But even GeneXpert can help us make a diagnosis. And so if we can get that sample, great. If we can send it for expert, great. And as we roll out next generation expert cartridges and the Expert Ultra, the sensitivity is even better. But if we get negative results and the patient has a classic presentation, they have advanced immunosuppression in the setting of HIV, they have a 2 to 3 week course that's progressive, worsening headache, they have other stigmata of TB on physical exam, we can start TB treatment empirically and even repeat the lumbar puncture later and make a microbiologic diagnosis. But we don't want to delay empiric treatment if someone's sick and we think of TB meningitis, because treatment is life-saving, and without treatment, patients die. Finally, just on our physical exam, sometimes in TB meningitis, we can see involvement of the choroid and the choroid of the eye on fundoscopy. And these small hypopigmented areas are classic choroidal tuberculoma. So if we can do fundoscopy, sometimes we can see that as well as blurring of the cup and disc margin, which can suggest increase in your cranial pressure. And then our management is similar to what we do for pulmonary TB, with 2 important exceptions. The first is that we extend the continuation phase of therapy for 10 months. So meaning rifampin and isoniazid is continued if this is drug susceptible TB for 10 months. So a total of 12 months or a year of TB therapy. And if we notice a tuberculoma on a CT scan, we may even continue beyond that to do a continuation phase of 16 months, because it's just so hard to sterilize the brain parenchyma. Finally, often patients present to us with their TB as their presenting manifestations, and then we diagnose them with HIV, and we're left with the question of when do we start ART? So normally we want to start ART as soon as they can tolerate TB therapy per our national guidelines very quickly, usually within just a few weeks. But the lone exception is in TB meningitis, where we try to wait about 8 weeks for them to tolerate TB therapy and clear the brain and CSF of TB so that when we start ART, we we don't cause worsening inflammation of the brain. And we know this, that early initiation of ART in cases of TB meningitis may be associated with worse outcomes. And we know this from some prospective studies that have been published, mostly from Vietnam. So I wanted to return to the poll question from our first poll. And this was kind of worded in a tricky way, but the false statement is C. So just because you get a smear or a culture expert on CSF, it doesn't mean that you've ruled out TB meningitis. And maybe I messed up here, Dr. Poloshin, should have given folks a chance to answer. But you know, what we really care about is thinking to make sure that we're capturing clinical cases. We tried our best to make a microbiologic diagnosis, but if we collect CSF and we don't see TB and the patient has a presentation that's highly compatible with TB meningitis, we don't have to withhold therapy because just unfortunately, the sensitivity of these diagnostic tests aren't perfect.
I'm going to do something, Dr. Herce. I'm going to share the results of the vote while you were talking. So
okay, perfect.
Can you see those results?
I can see those results. Good. And again, I can see we have I apologize for jumping the gun a bit, but I think we have a really smart crowd. So 87% got the right answer, and that's exactly right. So just because our CSF studies are negative, it doesn't rule out TB meningitis. And if you suspect it clinically, it's okay to start treatment. And even after you start treatment, you can go back and take another sample of CSF really to look for the genetic material for the Mycobacterium TB complex, which you can do on GeneXpert. You can even sometimes recover viable TB microorganisms on culture if it's been sort of less than a week. So I think all of this is to say, when you suspect it and someone's sick, start treatment, even if your culture data is unrevealing, and you can always obtain a second LP to improve your diagnostic yield if the patient is not responding or you still have some diagnostic uncertainty.
Thank you.
And 87% got the right answer, so that's really great.
Okay.
And then go ahead.
No, this was just addressing the first one. While a lumbar puncture is desirable, sometimes we do use your CTs and your MRI and the clinical picture because sometimes they're not able to get a lumbar puncture. As for CSF, when you are trying to make a diagnosis of TBM, you will notice on our wards, we don't typically send a sample for smear just because you need a large volume, actually. So this statement is true. The larger your volume, the better. So typically from the wards, would get 4 to 6 mils. That's usually not a good idea if you're trying to make a diagnosis of TB, if you're trying to isolate. So that's why those two are true. The second poll question from your deck, Dr. Herce.
Go ahead, Dr. Floshi.
Okay, so for this one, as discussed earlier, when you really suspect TB, you need to start as early as possible, especially the scenario he gave where you had a globular heart and everything else pointed to TB because sometimes echoes can delay. And the problem with delaying starting steroids and ATTs, you may end up with constrictive pericarditis, or worse still, even cardiac tamponade, because we know referrals sometimes are not perfect. So your threshold must be, your intervention should be timely. Dr. Herce, do you have another slide after this?
Yeah, I just wanted to open up to questions that came to mind or any other reflections from the audience. Thank you.
Thank you so much. Do we have any questions for Dr. Herce? You can actually just raise your hand using the icon, or you can type in. Dr. Lungo, please go ahead with your comment. You are welcome. As Dr. Lungu is preparing to ask Mongu, please.
Yeah, thank you.
Yes, Dr. Lungu.
Thank you, Sombo, and thank you, Dr. Herce, as well, for a very important presentation. Dr. Herce, I just wanted you to comment on two things. Now, one is on the amount of CSF. I think there was a study by CIDRZ, and I think in that study, it equally found that 5 mL was good enough to actually pick up TB from the CSF. I would like your comment on that amount, especially that most clinicians and patients as well may express some concerns on 15 mL especially. I know it's still safe, but they may have some concerns, especially that when you're actually getting a CSF, you're not only going to examine for TB, but examine for many other possible causes of the meningitis. Your comment on that one. Then the other issue I wanted just you to highlight is that on that X-ray that you shared, I saw some other features that were suggestive of TB. So it may actually help in just augmenting the reasons for commencing ATT besides the TB pericarditis features. So if you could also comment about the fusion on that X-ray as well. So those are the issues I want you to comment on. Over. Thank you.
Thank you, Dr. Lungu. And it's great that we have a TB expert on the call. So I really appreciate those insights. Yeah. So I think in our setting, the volume question is really a question about access to culture. So I think, if we have access to expert and we have access to like CSF cryptoantigen and good molecular testing off PCR, in fact, 5 mLs is really sufficient. That would be enough to do gene expert. We really only need 2 mLs for that. For CSF CRAG, cryptoantigen, you really only need an ml. And then you can do a number of molecular tests, including HSV, VZV, and an RPR. You could do that off the remaining 2 ml. I think the challenge comes if you are working with culture, and that's where the added volume is really helpful. So most micro labs will request somewhere between 5 and 10 mLs just for TB culture, just to maximize yield and get a good pellet if they spin it down and try to replate it. The other issue is if you are also wanting to do like a quantitative fungal culture for cryptococcal meningitis and documentation of sterilization of the CSF, that's where that larger volume comes into play. But for many of our hospitals that may not have, CSF culture, TB CSF culture capacity, I think 5 mLs would be more than sufficient. And then the question about the X-ray, let me go back. They're very good eyes. Yeah, so this is perfect. I think as Dr. Lungu is raising, the X-ray is not perfect, but you can see actually there is some perihilar prominence in the right hilum there. You can also see just over on the left side in the hilum is also very prominent, and there may be evidence of an old gome complex. I see an area of cavitation. Unfortunately, the superior portions of the X-ray is a little bit over-penetrated, but I do think, to your point, that there is also corroborating evidence on the X-ray that supports a diagnosis of TB that would make you feel more comfortable giving this, diagnosis. And then, certainly, in a perfect world, you would look for, in someone with this advanced immunosuppression, we would want to get a urine lamb. We would want to investigate the chest. We would want to get a sputum sample. Any corroborating evidence we can get so that we can make a microbiologic diagnosis of TB really helps clinch the diagnosis. So I think a good pair of eyes and X-ray can yield a lot of collateral information, as Dr. Lungu smartly points out. Thank you.
Thank you so much. Would you like to summarize so that we go to the case? Mongu, please go ahead. Very nice contributions on really looking at other places like urine lamb, looking at the chest X-ray closer. So you may have a very difficult diagnosis, but sometimes the answer is in something that's very easy to look at, like your chest X-ray. Dr. Zulu?
Folosini?
Yes, Dr. Mwinga.
Yeah, I just wanted to make a quick comment. It was indeed a beauty of cases that have been presented, and these are the cases or the challenging cases that people, also many clinicians actually are made to face out there. But one pair maybe that we need to also emphasize on for a severe form of TB like TB pericarditis or indeed TB meningitis is the duration of treatment. Having come from the ground, you note that most of the people, that diagnosis can be made, but the duration of treatment will still end at 6 months. So there's that paucity in adherence to the TB guidelines that for the severe forms of TB, indeed, the treatment duration should go to a year. So I just thought I emphasize that point. Over and thanks.
Very, very important point to emphasize that duration matters when you are dealing about TB spine, or TB brain. You need to prolong. Thank you so much, Dr. Mwinga. That's a very important observation. Please go ahead, Dr. Chikondi. You can go to your next slide. Ongu? I think they are talking.
Yes, yes, Dr. Poloshi.
Please go ahead with your case presentation.
Okay. Are you able to see our screen?
Yes.
Okay, all right. Okay, so we'll present, we have added another device, that's a phone, since we are kind of like having challenges a bit with the sound. Okay, Mr. Laston is here. He will take us through the case. Thank you very much.
All right, good afternoon, network. Yeah, I'm Laston Murikula from Mongo. I'm a clinical surgeon by profession. I'll present the case for Mongo. Okay.
Is it okay if we share this?
Yeah, yes, please. If you can share from there, will be great.
Okay. Okay, I'll have to stop sharing your screen and share this one. Okay, you can go ahead. Oh, thanks, Kote. You can go ahead.
Okay. All right. All right, Doc, next slide. All right, so we are sharing a case of a female 28 years old who was diagnosed with HIV in the year 2014 and was initiated on CATs and TLE regimen. In the year 2020, the patient was later transitioned to TLD. By that time, the facility had challenges with TLD. So this transition was made because of the issues with drugs which we had at that moment. Coming to December 2020, the client had a high viral load of 1,833 copies per mil while on TLD, and it was
Okay, Timongu, we have lost you. Okay, I'll pick up until they are able to join. So this lady came 6 months after. Yes, please.
Hello,
go
Doc.
ahead. Go ahead.
Are you getting me?
Yes, yes.
All right. So in January 2021, 2020, the client presented with high viral loads of 1,833 while on the TLD regimen. And we enrolled this client into enhanced adherence counseling for the 3 sessions which lasted for 3 months. Then in the year 2021, January, the client came through with the complaints of joint pains, night sweats, backaches, and then explained fevers. It was during that time that we
We have lost you. Dr. Zulu? Mr. Gondwe? So anyway.
I don't know why the network is switching off. Yeah,
Go
let me
ahead.
try to be fast. Okay.
Yes.
Yeah, so based on the complaints which the patient presented with, we were actually prompted to do a number of investigations to help us find the cause of these complaints. So we did the X-ray for the spine of this client. And on the 26th of January, we actually initiated our own TB. We had made a diagnosis.
We have lost you again. Timongo, we've lost you again. So essentially this patient was started on.
Sorry.
Please go ahead.
Maybe we can go to the slide.
The next slide.
Right. I've mentioned that we had started the TB treatment on the same date of January 2021 on the 26th. Yeah, so after 3 months of in-extra adherence counseling, I think the viral was still high. So this is the slide showing, all right. Okay. So yeah, this is a slide showing the lab investigations and the radiological investigation that we did. So we had done a chest X-ray as well, which was normal, and the spine X-ray, which wasn't normal. I think the comment on the spine or X-rays were that we couldn't trace the pictures, but so we were able to elaborate specifics on the abnormalities. Next slide. All right. That was just a picture which was depicted, gotten somewhere just to show.
We have lost you once again. So this is just an illustration of what a gibbous would look like, as Dr. Herce showed us. And you can see that—
Just give us the next slide on the questions. Sorry, our network has been very bad. So we also did a genotype, which the results are still not yet back. So from the cases which we presented, we came up with all these questions, which we thought the network could actually help us with, so that in future we will be able to actually give a comprehensive service to clients who could present in the similar way. So our first question was, what specific tools are available for diagnosis of EPTB? The second question is, how best can we manage this co-infected client who is still virologically unsuppressed on TLD, but responding very well to TB treatment? And the third question is, what is the best approach to OI screening of clients with advanced HIV in resource-limited settings? I think that's our case. Sorry, we had some hiccups with the network.
It's okay. We were able to follow, and thank you very much. This is a very good case. So in summary, the team is presenting a 28-year-old female who had an HIV diagnosis in 2014, initially started on TLE, but was transitioned to TLD due to logistical constraints. So they didn't really have a viral load on this lady. Subsequently, in 6 months into this transition, she actually had a viral load of more than 1,000, and a month later presented with constitutional symptoms that included persistent backache. The team went ahead and did quite a number of tests, including a sputum gene expert that was negative, a chest X-ray that was negative. However, they did a spinal X-ray where they saw some destruction of the vertebrae and reduction in the intervertebral disc. Subsequently, this patient had a kyphosis, as seen from the picture. Of note is 3 months into the ATT, the patient is actually doing very well clinically, but they note that despite adherence counseling on TLD with ATT, please take note, the viral load is high. It's 6,843. So their question is, what specific tools are available for diagnosing extrapulmonary TB? And number two is, how do we manage this lack of viral suppression in this lady on TLD? And what is the best approach to OI screening in patients with advanced HIV? Are there any questions for the team in Mongo before we answer these? Are there any hands, Kote? Any questions for the team in Mongo? I hope they will be able to hear. Okay. And Dr. Herce is responding to some of your questions in the chat box. So for me, the question I had for the team in Mongo is, did we add an extra dose of dolutegravir in this patient? Mr. Gondwe?
Yes. Hello? Hello?
Yes. Let's go ahead.
Hello, you're getting me?
Yes.
Yeah, we actually did add another 50 milligrams of dolutegravir.
Okay, so there was optimization, but do we know at which point it was added? Was it added when the ATT was started or when we realized she was failing?
No, we added the day we started the ATT.
Okay, so that's when it was added. I don't know if Dr. Lungu, if you are still around, would you like to give a go at question 1? Extrapulmonary TB, I know it's broad because, as Dr. Herce mentioned, there are many areas in the body where TB can sit. I always say it can sit everywhere except the nails and the hair. Otherwise, TB can be anywhere in the body, including the skin, the eye, the adrenals. Any tools specifically for extrapulmonary TB?
Yeah, thank you very much, Dr. Foloshiel. You've actually given a very good preamble to the response to this. So in essence, the tools for diagnosing extrapulmonary TB depends on the site. I'll give you an example of the abdomen. And also one of the things that we should all have, nurses, clinicians, is a high index of suspicion. There are certain features that are pathognomic of TB when it sits in certain anatomical areas. As I said earlier, let's take an example of the abdomen. So you can actually use, depending on the presentation of that patient, if there are lymph nodes, certainly you could actually do an ultrasound or CT abdomen. And in most facilities, ultrasound is readily available. So if you see that there are paraiotic lymph nodes, certainly married with other clinical features, that's most likely TB. And also going by, if there is ascites, there are certain other tools that you can use. You can bring on board a gene expert, but of course, a gene expert is likely to be negative. But you need to use ADA, which is adenosine deaminase. So in essence, all the tools that you've learned in this lecture are applicable for diagnosing extrapulmonary TB, starting from the geological tools, going to the microbiological tools, such as your gene expert, your microscopy, and culture. What is just important when you are faced with a patient who you suspect who have extrapulmonary is that you need to bring together the history, the physical examination, and what your tools are showing in what we call a constellation of the results and the clinical presentation. So in essence, there's no specific tool that you can say this, if it's positive, certainly it's TB, and if it's negative, certainly there's no TB. With TB, that's where the challenge comes in. So in essence, I think it's upon us to develop our skills, and I'm happy that this lecture has been well delivered. And it is this sort of skill that we ought to have. And once we embody and have this skill, certainly we will have less of misdiagnosis of extrapulmonary TB. Thank you, Dr. Foloshiel, for that. Over.
That's a very good explanation, and I'm sure it's well understood. It depends on where it's sitting. And of course, your index of suspicion should really guide you. We are in a high TB prevalent country. Dr. Sinjini, I think you have a very good question. Please unmute your microphone, Dr. Sinjini, and ask your question. This is in extra-pulmonary TB. So it's not in the lung. Should the children be given TPT? Dr. Sinjini, go ahead.
Thank you, Dr. Foloshi. Really, my question is just that, because I noticed in the presentation we spoke about having children that were contact to this patient, and knowing that primarily TB is an airborne disease. So initially you would expect someone to have pulmonary TB, then it seeds to the secondary sites besides the lung. So my question was, is TPT indicated therefore for children, particularly children under 5, that's my area of interest, for TPT and their contacts with people with confirmed EPTB? Thank you.
Dr. Lungu, what's the Zambian guideline for this extrapulmonary TB and TB exposure?
Yeah, so thank you. So one of the things that we have learned from various research, and I'm sure Dr. Herce will confirm with me or agree with me, that even the extrapulmonary TB, at one point they had pulmonary TB. And also what we have also found out is that some of the extrapulmonary TB also have some level of pulmonary TB, and they're able to transmit disease. As you heard when he was explaining on the X-ray, was also bringing on board that we, in an ideal world or in an ideal place, we actually have to make every effort to confirm TB microbiologically by doing collecting sputum either through induction or spontaneous, and also some invasive procedure like bronchoscopy and the like. So in essence, the take-home message is someone who has extrapulmonary TB, has some level of pulmonary TB, and they're able to infect others, and therefore their contacts, especially children below the age of 5, must be provided with TB preventive therapy. Ideally, it would be nice to actually test for latent TB where we confirm that these children indeed have TB infection. But in our setting, we have challenges accessing TST as well as IGRA. So as a public health actor, as a public health measure, children who are contacts of extrapulmonary TB too needs to be given TB preventive therapy. In essence, actually what we're even saying now is that even contacts of clinically diagnosed, and in most cases, your EPTB will be clinically diagnosed.
So that was a very important observation, Dr. Sinjini. So the short answer to that is yes, it is considered significant exposure. The moment you label someone as TB, whether it's meningeal, pericardial, it is considered significant exposure for the reasons Dr. Lungu has given, even if it's also clinical. So that was a very good question. Dr. Herce, do you want to take up the second one? How do we manage this patient who's not suppressed and not adherent in terms of her ART? She's doing well in her ATT, which is a bit unusual. She's taking the ATT but not taking the ART. How do you manage this patient?
Oh, that's a very good question, Dr. Foloshi. I think, we have data that shows if the patient is actually getting a second dose of dolutegravir, so that it overcomes the drug-drug interaction with rifampin, that really, in most cases, especially with the viral load that's hovering between 1,000 and 5,000, it's adherence. That's the issue. And we have some good data from a recently published trial called the Nadia trial, just published in the journal last month, when they were looking at patients who had received nucleoside reverse transcriptase inhibitors and then were changed to second-line treatment that involved dolutegravir in combination with the same NRTIs in whom we saw genotypic evidence of resistance. Most of the patients in vivo actually were able to suppress, which kind of speaks to the power of the integrase strand transfer inhibitors. And that tenofovir, when involved in that second line regimen, was non-inferior to zidovudine. So all of that is to say that in most of the data we see from the global south in cases like this, the TLD is likely to be retaining activity. So I would really emphasize on the adherence and maybe double check if she's taking her evening dolutegravir extra dose. And then maybe assign her maybe a lay treatment supporter or community health worker to make follow-ups with her and just make sure she's taking her medications. I think you could get a genotype, as was recommended, in a repeat viral load to see if they had acquired a mutation that conferred resistance to the dolutegravir. If for whatever reason she had prolonged periods without access to the evening or her second dose of dolutegravir. And in that case, she would need to be changed to a regimen containing Calitra. But I think that would mean referral. So I think, in short, enhanced adherence counseling to continue, treatment support, and sort of really doing some case management to understand barriers to adherence, getting a genotype and repeat viral load. And if that showed that there was a resistance mutation, refer to a higher level for third line therapy, I think that would be appropriate. But it's most likely going to be an adherence.
Sorry, we've lost you there, but it's very clear that we need to deal with adherence issues with this patient and make sure that she's taken. If she's not, that genotype would be very useful, but not that our lab currently, we are not running the INSTI resistance, so you only see NRTI and NRTI. But this would be very interesting, depending, because I'm not sure if Nadia looked at patients with TB. Did the Nadia cohort have TB? Dr. Herce?
No, it didn't. It didn't include folks that had concomitant TB. And so just to kind of maintain the dosing. So I think that is a question for a future study. Maybe you can lead it, Dr. Faloshi. Good one.
Because we had some in Bison, so that's very interesting to hear. So what is the best approach to OI screening of clients with advanced HIV disease in resource-limited setting? If you saw their previous slides, okay, we really ran through this one, but they really could not do most of these tests. I hope Dr. Civile has joined in. They didn't have reagents for CD4. They didn't have reagents for urine lamp. They didn't have reagents for a serum CRAG. They didn't even go as far as LP. So how do we approach testing in these resource-limited settings? Because of course, they didn't even give us a CD4. Is Dr. Civile here for that? Before I take it up, I don't know if Dr. Herce, you want to comment on that, OI screening in patients with advanced HIV disease in resource-limited settings?
Yeah, thanks, Dr. Faloshi. So I think, this is a challenge. I mean, we've made so much progress in access to quality diagnostics that I would say it would be ideal to kind of do a root cause analysis and see how we can improve access, particularly to urine lamp and cryptoantigen off serum, because those are part of the WHO advanced HIV screening guidelines, as is a CD4. So I think we want to follow those WHO guidelines whenever possible. That said, I think if you're, without those diagnostic tools, I think what you can try to do is make the most of a chest X-ray. Make the most of, in the old days, we would look at a total lymphocyte count. And when it was less than 800, the correlation with the CD4 less than 200 was actually above 80%. So you could get a differential if you had access to an FBC. If you have access to expert, I think using expert, as we talked about, on aspirates of lymph nodes or from sputum, and then just doing a complete history and physical, that's really probably the best we can do. But I'll let Dr. Faloshi add.
Yes, I think that's very well said. And this is a very good question. You can see the facility attempted to screen for TB using a urine lamp, but also I think we need to congratulate you for going a step out and you were able to make your diagnosis using X-rays. So we do have tools that are in our facilities that we can use, but in the context of crypto, in this case, it becomes very difficult. One, we didn't even have a CD4 count. But the good news is, that's why I was hoping Dr. Sibile had joined. There's really a lot of push from the Ministry of Health working with CHAI to make sure we have this simple. Yes, Dr. Sibile.
Yeah, I was unable to unmute. I don't know why. Say that I wasn't allowed to unmute. Yeah, I wrote something anyway in the chat. Yeah.
Go ahead.
Yeah, so what I wanted to say was, yeah, so these limitations are there. We have a lot of support, and we think once the logistic, pipeline gets opened up, as we get over this COVID, a lot of these things will improve. We'll have some improvement in the CD4 count. I don't think we have a deficit there at the national level in terms of procurement. I think there will be a ramp up in the LAM and the CRAGS funding is there. And just the good news is that now some of these even drugs are in country. Just to tell everybody that we now have flucytosine, it's here, it's in Zambia. Liposomal amphotericin B is in Zambia. So things are getting better, but we do accept, and the guidelines are flexible. So if you have someone who's acutely ill, we know the definitions from the guidelines. And if there's no CD4 count, that person can still be approached as someone with advanced HIV disease. Indeed, we can screen with other things. For instance, if you don't have a LAM, you can still get the sputum or other tissue or CSF to screen with a gene expert, which is available. Crypto, you can still do that, lumbar puncture. So while we want the algorithm to be followed in terms of screening, there's room to probably change the algorithm. There are some discussions right now. Dr. Foloshi is aware that maybe if the time some of these reagents for screenings are available, why don't we screen everybody? That's a question we'll answer from the implementation side in due course, other than waiting for that CD4 count sometime, which might not be available for other reasons. Yeah. So I think in a nutshell, the deficiencies in terms of reagents and medicines are there. We anticipate improvement in terms of, because of the budgets and the focus and quantification that were done, and also that the guidelines are flexible to use other means, including what Dr. Herce has said, the absolute lymphocyte count. I submit.
Thank you so much, Dr. Sibile. I see we had Dr. Lungu, Dr. Herce, and Dr. Sibile. The short answer to 3 is that there's good news. There's work in the pipeline. Some of these reagents will be at a facility near you. I've seen a question, Dr. Sibile, that I know you'll be interested in answering, not today. They're asking what the turnaround time for the genotype is, especially in this type of a patient. Right now, we are on the ground looking at what's happening at facility level in terms of genotypes. Are you getting your results back? The situation does not look very good. We'll be looking at this in a later session and discussing some more HIV-DR genotypes, but just keep that at the back of your mind. Dr. Lungu, Dr. Herce, and Dr. Sibile, we want to thank you. And most importantly, we want to thank our network that joined us for this session. We'll see you at a date next month, which will be communicated for another advanced HIV disease echo session. And it's a wrap.
Thanks, everyone. Bye.
Bye.
Thank you very much.
Thank you. Thank you. Goodbye. This is Mpika joining.
Thank you, Mpika, for joining. We look forward to having you next time.
Thank you. We look forward for that day, Madam.
Bye.
Tomorrow there will be another COVID-19 session. An invite will be sent out. It's at 12 hours. It's looking at the SARS-CoV variant in circulation. So we hope you join us at 12. We'll send you an invite.
This is Katete.
Noted. We will join tomorrow for that session, Madam.